This week on the BackTable podcast.
Now we have a tremendous amount of data that every single man with metastatic prostate cancer, as soon as they're identified to be metastatic, must undergo germline testing and somatic tumor profiling from the get-go. It's critically important because it's going to impact decision-making in the hormone-sensitive space and in the subsequent line space. The data around PARP inhibitor combinations, largely driven in the BRCA population, though I think the data from TALAPRO-2, and we'll see from TALAPRO-3 what the performance is across other, genes, and test early.
Hello, welcome in everyone to BackTable Urology. My name is Alan Tan. I'm at Vanderbilt University in Nashville, Tennessee. And tonight's episode is about the combination era. 4 trials have reshaped the landscape: PROpel, MAGNITUDE, TALAPRO-2, and the newest one on the block, AMPLITUDE, and perhaps a 5th one coming at ASCO. This pulled PARP combinations all the way back into the hormone-sensitive setting. And joining me tonight are 2 household names in Oncology, right? We have household names like Michael Jordan and Brad Pitt. But Rana and Emmanuel here are household names in Oncology. Why don't you introduce yourselves?
Who's going to be Michael Jordan and who's going to be Brad Pitt?
I don't mind starting. So Rana McKay, I'm a GU medical oncologist. I'm at the University of California, San Diego. So excited to be here with you all. It's an absolute pleasure. I've got a basketball in my background there signed by Steve Fisher, who attended our very first prostate cancer patient summit that we host each year. He's the Michigan 5 basketball coach, now coaches at San Diego State. So,
wow.
Well, it's awesome. And I think that
awesome.
football is led by John Elway.
And I'm Emmanuel Antonarakis. I am a GU medical oncologist, prostate cancer focused at the University of Minnesota.
Awesome. So let's get on with the program. We got some cases that we'll try to add some color to our discussion. But you both just came back from the APCCC meeting, right? And Switzerland. So welcome back. We're going to, if you can integrate at any point, like what you've learned from that consensus conference, that'd be awesome. But at the end, I'll probably ask you something about practice changing from that. But let's just start by talking about PARP inhibitors and mechanisms. So like Emmanuel, you're very basic science oriented. Why don't you explain to us your version of synthetic lethality? And for a general audience like urologists, medical oncologists, how do you explain it to a patient?
Yeah, so synthetic lethality, at the most basic level means you need to have a defect in pathway 1 and pathway 2 at the same time to cause the cancer cell to die. So if you've got 2 pathways that are both responsible for fixing DNA damage, for example, pathway B compensates for pathway A, and pathway A compensates for pathway B. So there's a redundancy built in by Mother Nature so that the most important process of DNA repair can occur. And to get into the slightly more technical terms, when a double-strand DNA molecule is broken, it can repair itself by a single strand repair, so it repairs 1 strand at a time, or it can repair both strands simultaneously. That's called a double strand repair. And if a carcinogenic agent or environmental exposure or drug causes a single strand DNA damage, the double strand pathway can take over and fix it, and the inverse can be true. So the main enzyme or protein that's responsible for those single-strand repairs is the PARP enzymes, mainly PARP1, which is the target of drugs like olaparib, talazoparib. The main enzymes or proteins that fix double-strand DNA breaks at the same time are the BRCA2 and related proteins, and those are sometimes called homologous recombination proteins. So you need to cripple both pathways to kill the cancer cell. The way that the single-strand repair pathway is crippled is by the pharmacological inhibition with the drug, in this case, PARP inhibitor. But then for that cancer cell to die, it needs to have the second half of that pathway, which is the BRCA pathway, also crippled. And the way that the BRCA pathway is crippled is not through a drug, it's actually the genetic or genomic inactivation. So for example, through a mutation in the BRCA gene or other genes. So if the BRCA gene is not mutated, if it is functioning normal, it's doing its happy job, then a PARP inhibitor is not going to make a darn bit of difference. That cancer cell is not going to be affected, it's going to survive, and the patient is not going to get a therapeutic response. Now, if the double-strand repair pathway is already crippled by an underlying genetic defect, either an inherited genetic defect like a germline mutation or a somatic tumor-only genetic defect, now that cancer cell relies exclusively on the PARP1 as its only way that it can repair single-strand DNA damage. And in that context, when you use the PARP inhibitor, that cell can no longer repair DNA damage at all. It accumulates catastrophic DNA breaks and it dies.
Very good. That was a great explanation. But for a patient, like, would an analogy like a spare tire analogy, like I usually tell patients cancer cells, like BRCA cells, are always, they're already driving on a spare tire because BRCA is broken. And then PARP inhibitors puncture that spare tire. And usually normal cells have a full set of 4 tires. But then with both of them knocked out, the cancer cell is stranded. Does that kind of resonate with patients, you think?
I've never heard it, but it was compelling when you just said it, so I like it. I'm going to start using it.
All right. Just make sure to credit me. Anyways, Rana, we always hear about, I hear a lot, Niraj says this a lot, where AR blockade actually induces BRCA-ness via like HRR transcript downregulation. Do you think that's actually what's going on? Why do we get a synergistic effect with ARPIs in combination versus single agent?
Well, I first would step back and say, I don't know that we've actually like definitively proven synergy. So I think there's a lot of, controversy in the field regarding the impact of PARP inhibitors combined with ARPs in the context of non-mutated disease. There's rationale that AR signaling helps tumor cells repair DNA, that blocking AR results in basically inability to repair DNA. So I think there's this rationale around that, but I think there's a lot of, I don't think we have like robust data that actually totally proves that synergy.
Yeah, I agree. It's all hypothetical, and these 4 trials specifically, have shown some conflicting results clinically too. So it's really hard to really piece that together. I mean, Emmanuel, like, what about if the mechanism actually is inducing BRCA-ness? Should the combo work differently or better with one ARPI versus the other, such as like Abi versus Enza? You think there's like a difference in how you match it up?
I don't think there's a clinical difference. In the preclinical papers, the androgen receptor antagonists like enzalutamide had a more profound effect on diminishing HRR function when the AR was inhibited, as opposed to a synthesis inhibitor. But I really don't think we know in humans. I think the reason for the trials having different results, which we'll talk about soon, may not be due to synergy mechanisms, but trial designs, doses used, side effect profile that may not allow the patient to maintain dose intensity for as long as the other trials, for example, and also drug-drug interactions between the particular ARP used and the particular PARP inhibitor used.
Okay. Well, we talk about the different PARPs in these combinations, right? Like talazoparib, niraparib, olaparib. Can you tell the audience a little bit of what your opinion is on PARP trapping potency? Which one has the highest potency versus, and which one might be responsible for more side effects because of that?
Yeah, happy to dissect. I think probably if you had to pick the agent that was the most potent with the most PARP trapping properties, it would likely be talazoparib. Olaparib was the first PARP inhibitor to really be approved in prostate cancer, and one of the newest kids on the block, or not newest, but kind of oldest kids on the block, I would say. It has moderate trapping potency, which basically freezes the replication forks, and replication fork results in cell death. Rucaparib, which is actually also FDA approved based off of Triton 2 and Triton 3, also has moderate PARP trapping. Niraparib actually has pretty higher PARP trapping, but not as potent of an agent. But I think, there's newer drugs that are also being developed. Olaparib, rucaparib, niraparib, and talazoparib are all PARP1/2 inhibitors that not only block at PARP1, but also PARP2. There are now selective PARP1 inhibitors that are being developed, namely saruparib, which is actually being tested in several large phase 3 trials across the treatment landscape.
Right. Okay. So, we're going to dissect some of these trials in a little bit, but TALAPRO-2 had a signal with all-comer population. And then I think PROpel also has somewhat of a signal in all-comers as well. What do you guys think? Is this a controversy, or is this a real effect? Do we think that treating all comers actually helps some patients, or is it something with how we're detecting the biomarkers? Are our biomarkers not sensitive enough to actually pick up patients that actually do have HRR, especially when some of these, like TALAPRO-2, allowed liquid biopsies as well?
Alan, I think we have a problem in the field, and the problem is that we know so much about the highly sensitive patients. And because we know which patients will respond better to these drugs, we've got two choices. We can bury our head in the sand and say, it doesn't matter what the biomarker is because we may get an overall benefit in the whole population, knowing darn well that it's being driven by 1 or 2 or 3 genes. Or we can say, now that we are in 2026 and we know how to measure and look for mutations in these genes, we're going to use that information because it'll make the discussion about risk-benefit equation more precise for that patient. So I do happen to believe that there is probably a very modest additive or slightly less than additive benefit when you combine a PARP inhibitor plus an ARPI in truly HRR proficient disease. But we also know that the canonical HRR deficient disease is going to have an enormous magnitude of benefit in the PARP arm versus the control arm. There has been some controversy or discussion about unknown or undetected HRR deficiency, maybe HRR deficiency that's not due to a gene mutation, or maybe it has to do with the transcript level or the protein level. And there are several companies out there that are developing transcription-based or genome-based, quotes unquote, functional assays for HRD. But of course, those are not approved at the moment in prostate cancer. Interestingly, there is one being used for ovarian cancer to select patients for PARP inhibitors in ovarian cancer. My response is that I like to prioritize these drugs for the patients that I know they will work the best in, because the side effect profile is going to be fixed. If the benefit is higher and the side effect is fixed, that benefit to risk ratio is going to be favorable. If the benefit is going to be minute and the side effects are the same, now that benefit to risk ratio flips and the risk becomes higher than the benefit.
Mm-hmm. Got it. Any thoughts, Rana?
Yeah, I think I agree.
Okay.
I think if we're going to break down PROpel, MAGNITUDE, and TALAPRO, they're each very different trials, even though I know they're all talked about kind of in a uniform kind of way. But I think it's important to tease out the differences and what was done in the context across these trials. When we look at PROpel, obviously it's the agents olaparib and abiraterone. There was no prospective testing in any way that was done in the context of that trial. All the testing was done retrospective. And when we look at the percent that were BRCA, it was around 10%, 11% of the trial. The percent that were actually HRR, around 28%. They retrospectively used a combination of both tissue and blood and had a 14 gene panel similar to the gene panel from PROfound, and primary endpoint investigator assessed PFS. When we look at MAGNITUDE was a little bit differently designed trial, NERA, ABBY, and they actually had two separate cohorts for HRR positive patients and HRR negative patients with kind of a futility check in the context of both arms. And that futility analysis, for what it was worth, included both looking at PSA response and imaging response, not just like rPFS. At the end of the day, the percent that were BRCA in the mutated group, which ended up proceeding, was about 22%. And they also used tissue and blood, and it was done prospectively. Talipro, different agent. As we said, there's a drug-drug interactions with enza-tala. The dosing of tala was actually less than if you were to use it monotherapy. Because of that, it's a very potent drug with potent PARP trapping. It was an interestingly designed trial because they had an all-comer population, but they actually had an enriched HRR population as well in the context of the trial. And there was prospective testing that was done based off of tissue and ctDNA. And if you did the breakdown, it kind of matched PROpel. 11% were BRCA1, 2, 22% were kind of HR altered in the all-comers. And so I think the kinetics of how these trials were designed impacts the readout. And I do agree with Emmanuel that there is a signal that we see in the non-HRR altered group. And yes, you can make some case that could there be some hidden positive patients in our calling of HRR negative in there because of the utility of ctDNA and because of the utility of archival tissue from any time point. But there is a hint of a signal, but is that enough to warrant like the risk benefit of using that combination in that individual where there's other life prolonging options that are available? And so, and I have to also add, and this will be the last point because I feel like I've been going on for a while, is these trials were all done in the context of patients not getting escalated in the mHSPC setting. There was a very small number, I think about just around 50 patients who had prior ARPI in Talipro, but that was like 50 out of like 800 patients that were enrolled on the trial. So I think in the modern era where the bulk of individuals are actually getting escalated, or there's an increasing population of patients having been exposed to an ARPI in the frontline setting, this discussion is somewhat mute. And the more relevant discussion is going to be driven by AMPLITUDE and Talipro 3.
Yeah, I agree. I think there's so much heterogeneity across all these trials. And as you mentioned, this trial started a long time ago where intensification with ARPI was not a standard of care. So essentially what you're saying, you already mentioned that MAGNITUDE's non-HR arm was stopped for futility. PROpel had an all-comer signal that was positive. I think the hazard ratio was 0.80. But then in their HRR population, that's where the greatest magnitude of benefit was 0.55. And then, of course, if you select for BRCA2, that's really where you get, the home run, if you will. So if Talipro 2 was the only trial with a statistically significant all-comer overall survival, what does that mean to you guys? Is this your de facto first line for everyone with mCRPC? Or are there some people that you might reach for a different combination?
Alan, my de facto is actually olaparib abiraterone. And there's two main reasons for that. One is, my personal comfort and experience with that. I've been using olaparib alone for almost a decade, 8 to 10 years. The second is I've become very puzzled by the significant side effects of the tala-enza combination. The cytopenias with that regimen are very, very significant. The grade 3 to 4 anemia rate is higher than 40%. that is enormously high. The number of patients that require at least one blood transfusion in TALAPRO-2 was more than 1/3. And of course, there's neutropenia grade 3, thrombocytopenia grade 3. The other thing, which goes without saying, the neutropenia and pancytopenia with olaparib Abi is about half. It's still there, but it's significantly better, about half. One of the things that I've become fascinated by is the overall survival in the BRCA subset. And to me, that's a litmus test of the efficacy of the combination in the group in whom you expect the greatest sensitivity. And I don't have the numbers in front of me, but they're going to be more or less accurate. The overall survival hazard ratio in the BRCA1/2 patients in PROpel was approximately 0.3, which is stunning for overall survival to have a 70% reduction in the risk of death by olaparib abiraterone versus abiraterone alone in the BRCA subset. If you look at that same analysis in TALAPRO-2, the BRCA patients, overall survival hazard ratio is approximately 0.5, 50% reduction in death. So when you compare like with like, the BRCA subset, even though they're different trials and even though there's all these caveats that Rana mentioned about the design, in my opinion, the strongest improvement in survival, which comes with a lower toxicity, is olaparib abiraterone. And by the way, you can give both at the full doses. Full dose olaparib, 300 milligrams BID, full dose abiraterone, 1,000 milligrams. Remember what Rana just said, when you give talazoparib and enzalutamide, the ANZA is full dose 160. The talazoparib is 0.5 milligrams. The monotherapy dose, talazoparib is 1 milligram. And despite that, despite the 50% reduction in the talazoparib, because of course the drug-drug interactions, you still get that significant cytopenia. So the last thing I'll say is this. There are different FDA approvals with respect to gene panels, and this influences my real choice in practice. PROpel and MAGNITUDE, BRCA1 and BRCA2 only. 2 genes. You cannot use the combination unless it's off-label use for a PALB2 patient or a CDK12 patient. TALAPRO-2, there is a 12-gene HR panel that you can choose from when you want to use talazoparib plus enzalutamide. So as I said before, in a BRCA2 patient or BRCA1 patient, I would choose the PROpel regimen. For a CDK12 patient, for a PALB2 patient, if I want the least number of headaches and rapid insurance authorization, talazoparib enzalutamide is better. And also that's where the evidence is, frankly.
Yeah. It's interesting. I just got an insurance denial for TALAPRO-2 regimen because the patient had Pluvicto first. Do you guys agree with that? I mean, they rationalized that it was technically not first-line mCRPC.
That's very interesting, yeah. I mean, it was also, these studies were done, much earlier on before we had introduction of, Pluvicto in the pre-chemotherapy setting. And yes, it's frontline, but that's quite interesting.
One of the things that came up at the APCCC consensus conference, we had to vote on 273 questions. And then we talked about each and every one. And there's going to be a manuscript in European Urology at some point. It was exactly the scenario that you mentioned, which was you've got a BRCA2 positive patient. They are now first-line mCRPC, either with ADT alone or ADT-ARPI. What would you use first? Would you use a PARP inhibitor first, save Pluvicto for later, or would you use Pluvicto first, save PARP inhibitor for later? At the APCCC, 2/3 of people in that scenario actually recommended using the PARP before the Pluvicto, which I would agree with also.
Yeah. My case was a CDK12.
Got it.
He had a CDK12. So that's why I didn't prioritize it prior to Pluvicto. But I would have totally agree. If you have BRCA2, this is very aggressive biology. We know these patients without anything intensification, their PFS is profoundly shorter, right? Which 5 years ago, I didn't think that PARP would move into the hormone sensitive setting. I thought it was not worth the toxicity. But now here we go. We have the AMPLITUDE data and it's FDA approved. And now TALAPRO 3 is going to be presented very shortly in a few weeks. So both of you guys, are you guys now using this in the upfront setting in HSPC?
Yeah, I mean, I think to piggyback a little bit on that, I think in multiple contexts, we've actually demonstrated, particularly for BRCA1 and 2, this is where the signal is the strongest, that early PARP is better. I think also Triton 3 showed us that when there was a comparison to docetaxel in the subgroup analysis, that the signal was stronger for rucaparib in that context. So I think we're beginning to see that emerge. We're beginning to see, the compendia of data supporting early PARP in the metastatic setting, again, particularly for that BRCA1/2 population that we know is associated with worse outcomes. And the AMPLITUDE approval is actually just for BRCA2. Actually, the proportion of patients with BRCA1 mutations is really quite low in prostate cancer. It's not the same as it is in breast and ovarian, where there's a predominance of BRCA1, but we see more of a predominance in BRCA2, and the approval in the US is for niraparib, abiraterone in the HSPC setting, or APMS, I should say, is for BRCA2.
Got it. All right, let's get on with the example case. Here you got a 69-year-old man, 22 months after ADT and docetaxel for de novo high-volume mHSPC. He's got a somatic BRCA2 biallelic loss, germline negative. He's got bone and nodal disease, PSA is 88, good performance status, but ARPI naive. What's your first move in the clinic? I think I already know Emmanuel's. Let's go with Rana.
Yeah, I mean, I think olaparib, abiraterone is certainly an option for this individual with a BRCA alteration. I think talazoparib, enzalutamide also makes sense. Yes, the toxicity is higher, but I also want to level set against how we grade and report tox in the context of CTC-AE grading. It doesn't actually capture the patient experience. And, a lot of times, a grade 3 anemia, hemoglobin drops below 8, you transfuse an individual. Not that I'm saying that isn't associated with an impact on the patient journey, but it's actually fairly manageable side effect profile, and you transfuse them, they don't necessarily recur, they're not getting repeated transfusions. It's sort of understanding the patient experience. So I think the data are robust. I think I agree with you that, olaparib's been around for a long time. There's a lot of experience with olaparib. Abiraterone's been around for a long time. There's a lot of experience with that. I think one of those two is a very much appropriate strategy. I'm a little less enthused about niraparib, abiraterone. I think just anecdotally, I think niraparib is just not as good of a PARP inhibitor. That study obviously had its, not say flaws, but it allowed patients to be on Abi 4 months into treatment. And so there's a lot of reasons for why, like if you look at the just like numeric numbers are a little bit different in the context of that study versus the other trials. But I think it's not as strong of a PARP inhibitor. And the thing for these patients, they only have one shot on deck, right?
Sure.
Like they've got one shot to kind of have their time. They're going to really leverage the benefit of the PARP inhibitor. So you really want to make sure that that's optimized for that individual as best as possible.
Right. And in this specific case, he had chemo too in the first line setting. So does that marrow preload steer you towards a less myelosuppressive PARP? I know, Emmanuel, you were talking a lot about the myelosuppression earlier. So is that going to steer you more away from Tala?
I think what's going to steer me is the current bone marrow function. Because I think you said 22-month disease-free interval, so it's been about 2 years since he's gotten the chemo, or at least a year and a half. A year and a half off of docetaxel, if his Hemoglobin is above 12, 12.5. Platelets are well above 150. White cell count well above 5,000-6,000. I'd be comfortable with both. I'm going to make a slightly bolder statement than the one Rana made. And I'm going to say that I cannot think of any compelling reason in this setting to ever use the magnitude regimen. And the reason is, and it's not just anecdote, it's hard data. If you look at the overall survival in the BRCA2 subset, there is no statistically significant overall survival, even in the best genomically defined group. So that severely diminishes my confidence. Why would I use that PARP inhibitor combination when we've got two others with OS hazard ratios of 0.5 and 0.3? And then you've got another OS hazard ratio with magnitude 0.9, non-statistically significant. Now, in the AMPLITUDE scenario, metastatic hormone sensitive at the current moment, we only have one PARP inhibitor-based combination, and that currently happens to be niraparib abiraterone. So yes, I will use that combination in the hormone-sensitive space, especially with a BRCA2 mutation. That's the only FDA label currently, one gene. And I've offered that to 2 patients in the last 3 months, and 1 has accepted it. So I have a personal experience outside of a trial of 1 patient on that regimen. And he's obviously responding, but it's hard to know what the response would have been like without the PARP, because this is a first-line, doublet setting. When TelePro-3 is reported, and assuming that is positive, I think the press release said that it was positive for, at least for our PFS, then it remains to be seen what the FDA chooses to do with the gene panel. And of course, it depends what the sponsor seeks approval for. Will Pfizer seek approval for only BRCA genes, only BRCA2, or BRCA1 and 2, or will they go for their 12 gene panel? I think that will depend on the data that we see. But I have a suspicion, without having any inside information, that we might see a broader gene panel approval for TelePro-3. And the only reason I'm saying that is based on the experience with TelePro-2, where there's a 12 gene panel to choose from.
Yeah, that definitely makes sense. So what are you guys looking for in TelePro-3? What are you expecting to see, first of all? And we know it's positive, but versus AMPLITUDE versus TelePro-3, those 2 regimens hypothetically will be FDA approved one day. How are you going to choose? Is it based on data, or is it going to be
I think it's going to be based on the data.
Yeah.
I think it's going to be really interesting to see the totality of the data, to see the effect size, to see the hazard ratio in the BRCA mutated groups. And I think also to look at, what's the signal across all the other HRR genes that are utilized in this context. When we think about AMPLITUDE actually allowed prior docetaxel to be utilized. And I think around 16% of the population, if I recall, actually were exposed to docetaxel. That's going to color your profile a little bit. If you have people that you're giving triple therapy to, it's probably a little bit more aggressive population. TelePro-3 did not allow concurrent utilization of docetaxel. No patient had that. So I think it's going to be interesting to see the signals, the hazard ratios. Also, again, how we track AEs. Like, the longer patients stay on a study, the longer patients stay on a treatment that is efficacious, the higher touch points that you have with that individual to ask, probe, and check for AEs. And there's almost like an ascertainment bias associated with therapies that have a longer PFS. So I think we need to understand the totality of the data. How long is the mHSPC period for? When does CRPC emerge? What's the performance of the control arm in this specific biomarker selected group in the mHSPC setting? This is going to be critically important, because the performance of the control arm from AMPLITUDE was really quite poor. When you look at and benchmark against Titan, Arches, Enzamet, Latitude even. The control arm really, I think, as would be expected in a biomarker-selected population, did not do as well. So I think that could also be colored by the design of the trial. So I think everybody is really eager to see what the data looks like. And the other piece, I think, was that trial did allow, as with AMPLITUDE, both ctDNA and tissue for classification of HRR status. So understanding the proportion of patients that had tissue only, ctDNA only, or both is going to also be important when you think about the outcomes. I think with a biomarker selected study, it's a little bit easier because to enroll, you have to be positive as opposed to is there a negative person in there that in actuality is positive? But then that kind of brings up the question around CHIP. But CHIP would then actually, you would blunt the signal if CHIP was present. So I think understanding all those kinetics are going to be really important. I think people are really eager to see the data that'll be presented as a oral presentation at ASCO by Neeraj in just a couple of weeks.
Yeah, excited to see that. So let's move on to continuation of that case that we just talked about. Let's just say that patient went on olaparib and abiraterone, but then 19 months later, we have a rising PSA, we got a new bone lesion, and one liver met. Get another PSMA PET scan, and it's avid. You biopsy the liver lesion, and it shows a BRCA2 reversion mutation. Now, you bring this to the tumor board, and we talk about, all right, do we do cabazitaxel? Do we do lutetium? Anybody think about even rechallenging with a different PARP?
I would try to get the patient on a POL theta inhibitor study.
Yeah, clinical trial is definitely going to be on top of that list. But let's just say we didn't have any clinical trial. Let's say they, live in Paducah, Kentucky.
Yeah, this scenario that you painted, Alan, is a poor prognosis one. Let's assume for a moment that he did not have the reversion mutation. The one thing that I want to point out is the totality of the data, both direct and indirect, strongly suggests that the taxane class is absolutely the wrong class of chemo to use in a BRCA patient. And the most direct prospective randomized data that makes that claim very strongly and clearly is the Triton-3 study, where the control arm in Triton-3, rucaparib was the investigational agent. The control arm could either be docetaxel or the ARPi switch. If you look at the subset of patients who did get docetaxel in the control versus the rucaparib, there's an enormous, very large delta with the RPFS. So that there and then tells you that a PARP inhibitor is always going to be preferred over a taxane. It indirectly tells you that taxanes are inherently more resistant. Patients with BRCA2 mutations are inherently more resistant to taxanes. So what are you left with? Let's keep Pluvicto off the table for now. If you want to go down a chemotherapy route, it would be a platinum agent. The problem with this scenario that you presented, though, is there's a very strong chance, and we know this from the ovarian cancer literature, that BRCA2 reversion mutations not only induce PARP inhibitor resistance, but also platinum chemotherapy resistance. In fact, the very, very first BRCA2 reversion mutation ever published was an ovarian cancer patient receiving platinum, cisplatin. The first reversion mutation in BRCA2 was published in a platinum-resistant ovarian patient, well before we were ever using PARP inhibitors. So I would not be enthusiastic to use carboplatin, for example, or even cabazitaxel plus carboplatin in a patient with a reversion mutation. Now, what about Pluvicto? There we have a problem too. Yes, it would be attractive to use it. That would be like the no-brainer response. However, unlike other radiotherapeutic agents, which might be more sensitive in BRCA2 patients, actually, a number of retrospective studies, including one led by Dr. McKay, shows that BRCA2 patients actually induce a relative Pluvicto resistance, or at least a more rapid progression. Unlike ATM mutations appear to sensitize for Pluvicto. BRCA2 actually do the opposite. They portend resistance. So for this patient, bottom line, I probably would use Pluvicto. I would be quite concerned about an early progression or maybe even a non-response.
Yeah. Okay, cool. Well, we talked, this whole conversation we're having is about PARP combinations, right, with ARSI, but Emmanuel, you were a lead author on the Breakaway trial, not to be confused with Kelly Clarkson's pop song Breakaway. But what would you do? What tell the audience about sequential versus combo and what you saw in that relatively small study, but I think really thought-provoking study?
The Breakaway study, which was a tiny randomized trial, was 60 patients, 20 patients per arm. So 3 arms, 20 versus 20 versus 20. They had to have BRCA1, BRCA2, or ATM mutations. Arm 1, they got abiraterone by itself. At progression, they could cross over to get olaparib. Arm 2, they started with olaparib. At progression, they could cross over to abiraterone, monotherapy followed by monotherapy. Arm 3 was the combination up front. Again, tiny trial, 20 versus 20 versus 20. Arm 3 had by far the most profound RPFS benefit. The RPFS was longer than 3 years in that combination group, in those 20 patients. The overall survival in that combination group was 5.5 years, which is pretty stunning. 5.5 years of overall survival. The second best arm with respect to PFS and OS was starting with the PARP, transitioning to the ABI afterwards. And then the worst prognosis with both endpoints was starting with the abiraterone and then PARP upon progression. The reason why this study has been mentioned a lot is because even though it's absolutely tiny, it's the only one that truly had, first of all, a control arm of the PARP inhibitor alone as opposed to the ARPI, because the 3 studies that we mentioned before, the control arm in all 3, PROpel, TelePro, MAGNITUDE, was the ARPI alone. So here we had a control arm, which was the PARP alone. That was novel. And the second aspect, of course, is the built-in crossover. So it was really a question of sequential, A followed by B, or B followed by A, or A plus B from the beginning. And A plus B from the beginning proved to have a much superior PFS, but more importantly, OS.
Mm-hmm. All right. Awesome. Great discussion, guys. So you guys just came back from Lugano in relation to PARP and maybe just in this entire space in hormone-sensitive prostate cancer where, we just had an ODAC meeting where 7-1 capivasertib was recommended to proceed with a hazard ratio of 0.80. Do you guys agree with that, first of all? Or are you guys part of that panel, first of all?
So I think that the take-home message, I think, for people listening in this context is now we have a tremendous amount of data that every single man with metastatic prostate cancer, as soon as they're identified to be metastatic, must undergo germline testing and somatic tumor profiling from the get-go. It's critically important because it's going to impact decision-making in the hormone-sensitive space and in the subsequent line space. I think that's an absolute take-home. I think the data around PARP inhibitor combinations, largely driven in the BRCA population, though I think the data from TALAPRO-2, and we'll see from TALAPRO-3 what the performance is across other genes. So I think that's really a take-home message, I would say, is test and test early. And retesting is actually important too in a subset. We demonstrated from the PROMISE database that actually you pick up an additional 10% of patients will have an actionable alteration on a retest in the context of advanced disease.
Great. How about you, Emmanuel?
Alan, I'll just end with something a bit broader. In February, we saw the publication by Dr. Armstrong and Morris and 50 other co-authors of the Prostate Cancer Working Group 4, which is a document designed to inform clinical trial design, not necessarily clinical practice. One of the pivotal recommendations in that document was to consider renaming the disease states previously known as hormone-sensitive prostate cancer to be renamed as androgen pathway modulation sensitive or naive, and to eliminate the word castration from the vernacular and call it androgen pathway modulation resistant as opposed to castration resistant. So in Lugano, we had a voting question on this. And the question was, are you willing to adopt the new terminology as proposed by Working Group 4, or are you going to stick with the golden oldie? And it was a 50-50 split, actually. So 50% of the panelists, and we don't know if it was more the American contingency that voted, if you asked the European and Australian that voted no, we actually don't know that. But it was about 50-50. So you can view that in two ways. You can view that as a large part of the world is skeptical, or you can view it as, gosh, only 2 months after the paper was published, already 50% of people are willing to change. So I guess it depends on your perspective. But the thing that I found fascinating, every session in this APCCC conference was spearheaded actually by a patient advocate. So the first lecture in every session of every day was given by a patient advocate. In the previous meetings, there was always one session devoted to the advocacy, but every session this year had a patient advocate leading it and giving the first lecture. During the Q&A part, when we were discussing the nomenclature change, there were a number of very vocal European prostate cancer patient advocates that actually disliked the new nomenclature. And I found that interesting because one of the reasons that Armstrong and colleagues recommended the change was because a lot of the US patients wanted us to take away the term castration resistant.
Yeah.
But it turns out that at least some of the European patient advocates that were in the room opposed two things. One, it takes away transparency in their minds because patients might not think that they're being chemically castrated. They might think that we've somehow developed these less toxic androgen receptor pathway inhibitors that are not going to have the same side effects. So it was kind of a misinformation in their mind. And the second is many of those patients actually wanted recognition for the amount of suffering that they've been through as castrated patients. And they thought that by removing the term, we're dishonoring the profound side effects that they've had to face. So very interesting perspective. And I would have never expected that. And I don't know, Rana, if you got the same sentiment or what your thoughts were on that.
No, totally. I absolutely felt the same exact way. I think listening in on patient support groups, advocacy groups here in the US, I think there's been a lot of aversion around the utilization of the word castration in the vernaculum for people with advanced disease. It's maybe cultural style. And I think, patient advocates were absolutely involved in the redesign of the working group. It was not done in a silo. And so I think that perspective is very interesting, is very unique. I think it's going to take evolution as we kind of advance, forward. How do we, even still now with continuation of AR targeting agents that are continuing to be tested, CYP11 inhibitors, now we're seeing AR degraders. Like, what does androgen receptor pathway modulation mean? Does that count? Does that not count? So I think the other really important thing is that Prostate Cancer Working Group 4 has now started to embed PSMA PET imaging to be systematically done in the context of clinical trials, and embedded some updated criteria around how to potentially call progression in that context. So I think it was incredibly enlightening to get the international perspective. And my suspicion is that actually, if you query different regions of the globe beyond Europe, Africa, Australia, South America, you probably will get a slightly different pulse, if you will.
Yeah, that's amazing. I mean, thanks for adding that to the conversation because I remember when Michael Morris brought this up at one of our Alliance meetings, maybe a couple of years ago. And, years later now we're actually incorporating into PCGW. So great. Well, awesome. Well, in summary, I think tonight what I'm hearing is biology drives benefit, right? BRCA2 drives the magnitude of benefit. HR negative question is still kind of open, right? But the bar for combo for everyone keeps getting higher and higher, and survival as the survival data matures. So, but bottom line is, as Rana mentioned, we got to test. Every decision we made tonight started with a genetic test result or genomic test result. Thank you so much, Rana and Emmanuel, for joining tonight. Your expertise is invaluable. And good evening, everyone. Take care.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.